Why don't we get started here? First, I want to thank everyone for taking time out of their day, their morning, their evening, for being a part of this webinar session. This session is all about evaluating excursive functions, which, as Dr. Kerstein is going to show you, is a very important part of understanding the occlusion, and you're going to find how valuable T-scan is for that part itself. Just some housekeeping things here. If you have any questions, there's a Q&A section down below that you can type in a question that we will probably answer towards the end of the webinar. But if I can answer it even before then, I'll try and answer it myself. At the end of the webinar, there's also going to be a survey, I believe. If you can take a few minutes out of your time just to complete that survey, that would help us quite a bit as well too. So I think most of you know Dr. Robert Kerstein. You know, obviously he's a global speaker, he's a book author. He has a lot of research that he's done on the T-scan technology and digital occlusion. So we're happy to have him here talking to you about evaluating excursive functions with your T-scan. So without further ado, Dr. Kerstein, the floor is yours.
Thank you, Shane, and thank you, TechScan, for hosting this educational session on excursive function with the T-scan. As Shane pointed out, excursive function is extremely important. You cannot succeed in dentistry only adjusting closure or only evaluating closure and balance, because people function by chewing, and that's where excursions come into play. The limit of chewing is, excursions are the limit of chewing. In other words, if you chew to the left or the right, you're making excursive movements. You don't chew as far as we might measure an excursion in a T-scan recording, but what's found in the excursive T-scan recordings has a huge impact on chewing and function. And so I'm grateful for the opportunity to talk to you all tonight. Again, thanking TechScan for supporting this webinar and this educational continuum that we've been on. Last time I spoke about the force versus time graph. This time we'll be talking about excursions. Let me just hide my panel here. There we go. So welcome, and thank you for the opportunity to teach you about the importance of excursions and how the T-scan technology can help you with your excursions. Okay, Shane gave me a small introduction. I'll just finalize it a little. I've published over 100 peer-reviewed articles on computerized occlusal analysis, which is mostly on the different versions of T-scan, T-scan 1 to T-scan 10. I've published on them all, as well as on other biometric technologies like EMG and jaw tracking and chewing function. And I've written a number of textbooks chapters that involve T-scan and digital occlusion. I'm really, my focus is to educate and train you doctors who want to learn the science of digital measured occlusion, which is really using metrics and numbers and outcome measures, both to treat someone and to know you got a good result, or to measure them diagnostically to understand what's wrong with their occlusion. The science of digital measured occlusion is a completely different animal than traditional occlusion, with wax and silicone and bite paper and guessing at the paper marks and all the things that, if you have a T-scan, you're well aware of how different computerized occlusion really is. And so the science of digital measured occlusion has been evolved now since 1984. And we have 5 research volumes that have thousands of pages on all the applications of T-scan, T-scan in orthodontics, T-scan in prosthodontics, T-scan in implants, T-scan in general occlusal diagnosis, T-scan in TMD, T-scan in posture, T-scan in toothache, T-scan in cold sensitivity, and many, many more very important things that impact your practice every day. So digital measured occlusion actually has solutions for many of the problems you face in your office that traditional occlusion has found no answers for. So if you're interested in learning more about digital measured occlusion, please reach out to me directly and we can talk a little bit about that a little later on. Now, the T-scan and excursive function. There are many ways to look at excursive function with the T-scan. The first one is to play the force movie, to play the recording and observe the transitions of the forces and the columns and where the data of the tooth contact force information changes across time. And that's, of course, very useful. This is one that's probably the most important skill of all, and we talked about this last time, reading the force versus time graph. And that means reading it without playing the movie, knowing what this means, what the whole graph means, but the excursion starts here, and we're going to focus on here tonight as opposed to this side, which is biting down and into MIP. But this form of the force versus time graph, this is what you're trying to achieve whenever you record a movie. Patient bites down, holds their teeth together as best they can, and then slides in one direction. That's how you get a great excursive recording. And we'll go over recording a little bit as well. But reading the force versus time graph is the most essential skill of being a sound T-scan user. It allows you to really see the entire movie from start to finish, know if you got a good recording, and also understand what the recording means. You can also evaluate excursions with the timing table, but the timing table depends on what you do with the graph. So if you, for example, choose not to put the C line in the right place and not to put the D line in the right place, you won't get the correct disclusion time. The C to D increment is the excursive disclusion time. And the same applies to A to B. If you don't put the B line in the right place, you won't get the correct occlusion time. So the timing table is really a reflection of the graph. So whatever you're seeing here is really set up here. And the last way is to follow the center of force excursive trajectory. So the excursive trajectory is separate from the closure trajectory. So in this image, this is the closure trajectory. This is where the patient bites down from A to B. From B to C, they stay here in this little circle. And then at C, they move and make an excursion. And this happens to be an excursion to the left. The thing about the center of force, we'll talk about it in much more detail. It is not the patient moving left. It's the forces changing, favoring the left. The patient may be moving right, but if the left side is really problematic, the center of force will move left, even though the patient is moving their mandible to the right. And I'll show you an example of that. So these are the 4 ways that you can understand the excursive function. And of them all, as I said, this is the one that is the most important, the force versus time graph. Now, a little review. I think it's important to review, even though some of this came out of the graph session. If you want to have great excursive diagnosis, you have to have high quality excursive recordings. That's the only way you can make precise evaluations of your excursive function. So recording is essential to getting data that you can analyze effectively. And so your recording skills have to be top notch to be able to see an excursion clearly in the data. A few important things to point out in your settings, very important. Go to the Advanced tab, make sure you're recording in turbo mode. This is critical. Turbo shows you so much more detail. It cuts every frame, every single non-turbo frame into 3 frames, and it separates out all the subtle changes in force across time that you can't see if you don't have turbo recording on. So this is really essential. And also you want to make sure your excursions are all labeled. When they're labeled right, left, or protrusive, they come out in quadrant view. And we talked about quadrant view last time. That's essential to be able to diagnose excursive function. And again, we'll talk about these things in detail. If you do not have your settings set up correctly, you can find quadrant view under the view menu, view, arch, and quadrants. And that will take the 2 colored graph, the black line leaving the black line out, the red line being the right half of the arch, the green line being the left half of the arch. It'll turn it into a 4-colored graph where the blue quadrant is the blue line, the blue is the posterior right, and the orange quadrant is the posterior left. And this is essential to being able to analyze your excursions. This part may be a little bit of a review, as I said, from the graph session, but I think it's important all of you reacclimate to understanding the graph. First, reading the graph means looking at this picture and knowing what it means, and we'll talk about that in a second. So that you have to be able to read the black line. The black line is total force. Here, the black line is saying the patient bites down weakly, struggles to get to their MIP, can't do it, is made to squeeze harder, they waver some, and then they make their excursion here. And in their excursion, they have friction. That's the steps in the black line. The red line in the quadrant view represents the anterior right quadrant. So that's, again, everything mesial or medial to the, no, anterior to the canine. I'm sorry, anterior to the first premolar. And the red line in this example has very low closure force. And here it's trying to take control of the right excursion, but it can't do it because the posterior blue and the orange lines are compromising the anterior guidance. And so reading the graph is a skill you must develop if you want to be effective. The green line is the anterior left quadrant, everything anterior to the left first premolar. And here the patient's going to the right, well, I'm sorry, here the patient's biting down, holding their teeth together. Here's where they go to the right, and you see the left anterior quadrant quickly drops out. That's because it's not involved in the right excursion. The blue line is the posterior right quadrant, and the orange line represents forces in the posterior left quadrant. So if you were to read this graph, this is how it would be summarized. When the patient bites down, they struggle. They can't get to full force unless they squeeze hard, and then they begin their excursion. When they do that, their right posterior quadrant is the early control, which falters, but at the same time it falters, the balancing side takes control, and then it falters, and the anterior guidance actually starts to take control, but then it fails as the blue posterior right quadrant takes control and then guides the excursion all the way to the end, just about until the anterior guidance finally takes over here at D. And while that quadrant is operating, the posterior left is operating. So this is actually a very poor right excursion. This is a problematic right excursion. And that skill, understanding what's going on here, is something you, the user, need to develop. Now, in the graph, there are the timelines, and this is just, again, a quick review to reacclimate you. The A line is first contact. Generally, the software places that at the beginning of where the black line begins to rise at 1% total force. The B line marks static intercuspation. Static intercuspation is where all the contacts that are going to form, and then the patient squeezes to full force. So B is not maximum intercuspation, it's static intercuspation. Here the patient is squeezing hard to get to higher force, get all their teeth to load fully, but notice the quadrant lines don't change very much. That's because there's very little happening in terms of them increasing in force level or in contacts. Whereas between A and B, the colored lines rise, they drop, they change a lot. But once they get to B, they kind of stagnate, and that's a marker for intercuspation. The person is intercuspated. The C line is the beginning of the excursion. That's where the patient now moves, in this case, to the right. And the D line marks when they finally reach their anterior guidance quadrant 100%. And that's why you see D is way at the end here when the red quadrant finally gets to the top of the graph. In between is all this working and non-working contact that's compromising the anterior guidance, actually displaces it for a period of time, makes it really fail. It gets to 0, then it slightly comes back, and finally it comes back. So this is a really good example of a problematic excursion. When there are steps, that's friction, and we'll see a lot of that tonight. And the difference between where the excursion begins and where the anterior guidance takes over 100% is called the disclusion time. The disclusion time is the distance in time between C and D. In this case, it's 2.72 seconds. And it gets, in the timing table, it gets a red stop sign because 2.72 is way too long. Healthy is 0.4, 0.5. Right. And so this is a problematic excursion. The patient has muscle tension. They can't do the closure well. They're forced to squeeze. They waver. They have dysfunction. This is, again, the beauty of the force versus time graph. It shows you the entire recording. You just have to be able to understand what it means. And of course, that's one of the reasons we hold these sessions. Now, the last element of recording well is your sensitivity. Someone just sent me an evaluation from another part of the world, and they had like 12 pinks in their recording. You can't record well with lots of pink. What you want to use lower sensitivities and coach the patient to bite hard, right? You want the sensor to resist them a little because then you can see dysfunction in the recording. So you're trying to use the least amount of sensitivity that will give you 1 to 3 pinks. Too much pink, you wash out the dysfunction, you wash out the friction steps, and you actually improve the balance falsely. The more pink there is, the more balanced is the bite. You don't want a lot of pink. So ideally, 1 pink at 100% total force is perfect sensitivity. 1 to 3 is very useful sensitivity. So that means when the person is at maximum force in the recording, there's only 2 or 3 pinks on the screen. Now, here's an example of flawed sensitivity. And why would the sensitivity be so high? Well, I'm imagining that the doctor who made this recording is finding that their patient is struggling to give them data. They're having a slow close. This A to B is very far apart. The black line moving horizontally is a very slow close. They struggle to hold their teeth together, and here they make their excursion, and they struggle to do that. And so I imagine the doctor raised the sensitivity to try to get better data. It's better to keep the sensitivity lower and to make the patient struggle to do it and make them bite hard. That's what I'm talking about. That's called coaching the patient mid-excursion. You'll hear me do that in a second. This is much better sensitivity. This is 100% total force, the highest point in the black line, and there's 1 pink, right? That's the kind of sensitivity you want to be working with. And you have to preset that up before you record. Right? So you just don't stick the sensor in and start recording. You've got to do a lot of things, actually. Make the dental arch match the patient. For example, here you see there's no premolars. First premolars, they've been taken out. You have to do those things. And the quadrant line always belongs between the canine and the first premolar bilaterally. Those are important things. Okay. Now, let's talk about excursions. The first and most important thing to realize is that having canine contact, having class 1, doesn't mean the patient discludes well. And this is something that you'll see more and more of as you begin to record properly. Having canine contact means the patient has the ability to disclude, but they won't disclude in less than half a second unless the guidance is extremely steep and they move very fast. And so you're going to see in this presentation a lot of lack of disclusion so that you can understand what it should really look like. Also, it's also important to state that the vast majority of recordings you're going to see tonight are right and left excursions, and that's because people chew right to left or left to right. Protrusion is not a critical excursion comparatively. And it's not that it isn't important, but none of you are going to bite down and chew front and back. You're not going to slide forward and back hundreds of times while you're trying to chew up your steak. You're going to incise the steak once. You're going to move the bolus of food onto your back teeth, and then you're going to chew right and left. So right and left is really the critical excursions. And just to show you how much that plays out, in all the disclusion time reduction studies, which there are over 100 in the literature, you'll see there are very few protrusive movements treated or analyzed. It's always the right and left movements. And we can talk about protrusion separately from like when it's important to do. We teach that in the disclusion time reduction courses. But for today's presentation, just realize that right and left is what you have to master. And then you'll have much better control over diagnosing someone's occlusal problems, and you'll have much better control over understanding their functional occlusion. Okay, so I'm going to show you a recording. I think I showed you this before. It's important that you pick up on things that I'm doing. And I'll try to talk over some of the sound, but essentially you want to watch how I look at the screen before I turn the movie on, how I tell the patient when to move, because I'm watching the data, and I'll show you with the mouse. So this is recording to the right. I have a blank screen up. Someone's talking in the background. I'm placing this on her teeth. Now watch how I look at the screen, and then when I look at the screen, now I'm going to hit the button on the handle. Now I give her the instructions to bite down, and I watched it, and now I tell her to go to the right. So I'm watching the whole thing, and then once it gets all the way out to the right, then I turn it off. And I can tell from watching the recording what happened. I can't tell everything what happened, but I can tell that she had premolar guidance, that she didn't disclude her on her canine, and she is class 1, right? Now this is her recording. So here's where she bites down. Here she struggles. She maintains contact well in MIP, and here she goes to the right. So playing the movie, we can see a lot more. But again, you're going to see this form of all the recordings. This is the secret to getting good excursive data. Why? Because the patient leaves the excursion well digitated, fully engaged in their MIP, and then they move here. Now, if we watch the movie play, we see some amazing things. We see friction. We see premolar guidance that I told you happened. Watch that again. Friction, group function, premolar guidance, late canine guidance. I saw all of that by watching the movie be recorded. You have to be able to do that, to know when to give the patient instructions during the recording. Okay, that's playing the right one. Now let's look at the left one. Now with the left one, this time watch the sequence of events again. I'm putting it back in her mouth. Watch how I turn around. I look up at the screen. Then I hit the button. Now I tell her what to do. And now I tell her to go left because I saw the data come up and stabilize. It's so critical to watch the screen. It's so critical to watch the screen when you record. Otherwise, you have no idea if the patient did what you wanted them to do. And sometimes they won't do what you want them to do, and you can make mid-recording corrections. You can say, no, Mrs. Smith, bite down much harder, squeeze harder. Then when all the colors come up and you see a few pinks, then you say, now go left. But you can't know those things unless you watch the movie happening in real time. And that's one of the great advantages of the teaching, is real-time recording. See if we can get past it. Okay, so here's the left excursion. Oh, let me stop it. Hold on. Here's the left excursion. Patient bites down, holds their teeth together, lets go a little, but maintains MIP very well. Now goes left. Okay, so what happens when she goes left? Let's see. Friction, group function, balancing contact, canine not working, ultimately reaches the canine. All right, watch it again. Forces changing in the posterior left, some go down, some go up. Balancing contact, working side group function gets worse, canine working, failing, and then finally taking over. All right. All of those transitions took place in 1 second. None of what you can see without measuring the T-scan, without measuring with the T-scan in this way. Bite, hold, slide in one direction. Not slide in all the directions, not go right, not go left, not go forward like the concept of with the Gothic arch. Each excursion is its own recording. That's how you get really good data. And then things like the timing table showing you the disclusion time, for example, is based on, is the C line in the right place? Is the D line in the right place? Those are skills we went over in the graph webinar, and they apply to managing excursive diagnosis, right? Very important. Now, I may have shown you this before also. What is excursive friction? Well, you see it in the T-scan with the steps, but watch it clinically. Again, if I showed it to you, I'm just reiterating these important things. Notice how the person chops through the excursion. They can't just freely go to the, in this case, to their left. In this case, you'll see it going to the right. You'll see them chop and stop, right? And stop and chop, right? That's because their back teeth are rubbing together. That's what causes the steps in the black line. And these are two really good examples of it. Okay, so playing the movie is obviously an important thing to do. But as I said, the real skill comes from reading the excursion in the graph. So let's look at some examples of that way to look at the T-scan, to look at excursions with the T-scan. So here you see a patient has canine guidance bilaterally. When they go right, they don't disclude, which we're going to talk about why that is. When they go left, they don't disclude. Okay, so here's going to the right. Now, before we play the movie, let's read the graph, right? That's the skill we're trying to develop. Notice the shape is the same, right? In this graph, at C, the patient struggles to begin their excursion. Now, they may just be letting go of MIP. They may be opening slightly, and they may actually begin the excursion right here. So watching the black line is critical. Then there's friction, right? And then they finally reach low force. And this has a group function to the right that controls the guidance most of the way. And then here, the posterior group function is replaced by the anterior guidance, which is the red quadrant. At the same time, the balancing side does not go away. It hangs around for a long time. And finally, the D line is placed where the last posterior quadrant reaches 0% force. So it's not right or left, it's the last. So the first one is the orange quadrant. See, it reaches 0% force here. and maybe a little bit more here. But the blue quadrant, it doesn't reach 0% force until here. And that's where the anterior guidance quadrant reaches 100%. And that's where the D line goes. So now if we play that movie, right, you'll see all those transitions, right? You'll see the working side group function. You'll see the balancing side maintains contact. The group function persists. The balancing side persists. The orange and the blue lines are persisting. And then finally, the anterior guidance takes over, right? And that disclusion time is 2 seconds. And that's what it looks like on carbon paper, right? But again, can you see the transitions? Can you know what's wrong with the excursion? Yeah, grossly, but not microscopically, not neurophysiologically. With carbon paper, all you can do is mark the teeth and see which ones are hitting incorrectly. Now, here's the same patient going left, right? So if we read the graph, which is the skill I want you to develop, now he closes slower. So he got tired from the last recording. He can't bite as fast. So A to B is spread out more. The black line takes on a more horizontal character, and he slowly squeezes up to full contact. And then right here, he begins his excursion. So when he begins his excursion, the orange quadrant takes control. This is the left going left. So it's a left excursion. The blue quadrant, the balancing side, maintains some low-level blockages. The anterior guidance quadrant, the green quadrant, doesn't really work until out here when the group function begins to dissipate. But then the group function and the anterior guidance run together. So that's probably premolars and canines in contact. And then the anterior guidance fails, which means the canines come apart and the posterior teeth take over, right? So that's not a good excursion either. So let's play that and watch all of those transitions. So the left side group function is going to maintain control. You see some forces go up and then they begin to drop, right, and transition. The balancing side maintains one low force contact, and then the guidance is shared between the anterior teeth and the posterior teeth at this point in the movie. And this is what I mean about reading the graph. I was able to tell you all of those things without playing the movie. That's a skill you need to develop to be an effective T-scan user. Where does the C line go? The C line goes where the horizontal period ends. So this is where the excursion really begins. See, the horizontal period is a slight uptick here, but it's not enough to commence to be excursive commencement. Plus the total force line drops when the excursion begins. And the D line goes at the far right border of the graph because the anterior guidance failed. And so there's infinite disclusion in this case. So even though it reads 2.03 seconds, the C to D time, this excursion could be infinite. Now, then we corrected the right excursion and the left excursion, and we made our adjustments. Well, how did we do? Well, if we look at the paper marks, it looks like, yeah, maybe we discluded this person. Now we only have stops in most of the marginal ridges, cusp tips, central fossa. We have no more, very few lines anymore. But reading the graph shows you the truth. Look at the blue line. There's a group function still present. The balancing side, the orange quadrant drops out. Now the time is only 0.3 of a second, but this shows you the power of the T-scan. Even at 0.3 of a second, it's showing you there's a group function that remains, that your eye can't pick up in this medium, in the paper mark. See, there's a group function. It lasts for a long time. This contact is that contact. Now, you may say, that's not a contact. That's an artifact of the paper marks. No, watch the movie again. Watch where this is, right? Mesial lingual of 3, right? There's the lingual of 3 right there. And that's the contact, even though the guidance is working. So the graph shows you incredible detail, right? And you have to be able to read it. So let's say the patient came back and said, you know, my jaw pain is much better, but my headaches didn't change much. And then you make a right recording and you see this group function. And you're like, yeah, I got to make this better, even though it's 0.4. Maybe I need to make it 0.2 for this person. So what would you fix? Well, you'd look at things like this line going up the cusp. You'd look at this area where there's lingual to lingual contact. You'd certainly look at this area where there's lingual to lingual contacts, which we detected in the data, right? Anything like this going up the cusp, that's all group function that still remains. Now here's going left. What do you see going left? Reading the graph. There's a group function. The orange quadrant is posterior left, and then it dissipates. The balancing side drops out pretty fast. They actually both drop out around the same time, but the orange quadrant goes slightly up in force, whereas the blue quadrant goes down in force. So the group function is still somewhat prominent, again, at 4/10 of a second, which just shows you the power of the T-scan, right? And so if we watch this movie play, you'll see there'll be a group function here. As the center of force moves towards the left, you see the group function persist, the canine area is taking over, but the back teeth aren't coming apart. They're still balancing contact. And ultimately, the guidance discludes the patient. So if we wanted to fix some of these things, let me stop this movie. Let's say we wanted to improve the disclusion time by 1/10 of a second. What could we work on? Well, we could work on this right here. We could make this into a cuss tip rather than into a line. We could take this and make it smaller. We could remove that line and only leave the contact right there. We could leave only this marginal ridge and take away stuff like this that's behind the marginal ridge contact, that lingual to lingual contact. Now, you may be saying, those aren't real contacts. They're real contacts when you use 20, 30 micron carbon paper, not when you use 80 to 100 micron carbon paper. Then you get all kinds of artifacts. But 20, 30 micron carbon paper, you're going to see flaws. That's a lingual to lingual contact. When the person goes to the left, this gets rubbed. Right? And this is lined up with the left side. So these teeth are lined up with the left side of the T-scan. Now, why is it that we have all these class 1 patients that really don't disclude and should have very good canine guidance, like this patient, right? Look at the steepness of this canine. He should disclude. But watch what happens when he goes to the right. He doesn't disclude at all. Right? He's riding down the canine and all the back teeth are staying together. The question is, why does that happen? It doesn't happen on an articulator, right? But in the human, it does. And it's very simple why this happens. And it's not well understood. Basically, when the muscles contract to move the mandible to the working side, the condyle is elevated into the disc, which is soft. So the condyle goes north as the muscles contract to move the mandible. That raises the bottom end of the mandible, the back end of the mandible, the distance that the condyle sinks into the disc, and that keeps the back teeth together. And this occurs right around the central fossa. So this is why you see here the patients begin their movement and there's no disclusion yet. But maybe if they get out to the tip, they might have visible disclusion, but not measurable disclusion. And that's because of this phenomenon. The condyle is elevated into the disc, and that raises the back end of the mandible. And it happens in prosthetic dentistry. It doesn't matter that you have canines in contact and ideal, crown and bridge forms. When you actually record with the T-scan, you see steps in the black line in this large reconstruction, which the patient required 8 visits to get comfortable. The 8th visit was one where the dentist had me come to his office and teach him how to use the T-scan. All right, so here's this excursion going left. Look at the chopping of the columns. That's the frictional steps. All right, watch it again. Chop, 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 right? That all happens. This is maybe 4.5 seconds. That's 5 seconds. So all of that friction is in a half a second. None of us can see that with our eye. And so the T-scan detects these things that we can never see. Okay, so that's reading the graph. Now, the next feature that's really wonderful for analyzing the excursions is the center of force trajectory. And the timing table, as I said, is along for the ride with the graph. So we're not going to talk much about the timing table other than if you don't set the C and D lines in the right place, you won't get the right timings. If you don't set the A and B lines in the right place, you won't get the right timings. So you'll get misinformation here. So again, it comes down to the graph. Okay, now the center of force. So you'll understand the center of force. The center of force moves towards higher force and away from lesser force. It's not the patient moving in those directions. Many times it is, but many times it isn't. It's force changes at the tooth level, rubbing together, transitioning, that cause the center of force to move around the dental arch. And its excursive pathway, that's this piece, not the closure pathway, explains, does the anterior guidance mechanism really work? Right? And there are many different shapes that are repetitive that the COF takes that show you problems in the occlusion. So this is an ideal pattern. Patient bites down, they have a straight line center of force to the balance point, and when they go to the right or they go to the left, the center of force goes sideways at an angle towards the canine. But that is never really what happens without therapeutic intervention, right? Meaning shortening the disclusion time, making the anterior guidance really work well. Typically, what we see is the patient bites down, and then they might go to the right, and then the center of force will loop around and go back to the left. Or they'll be going to the left, but instead of it going towards the canine, the center of force goes to the back teeth, which means that forces are going up and back. Or if it goes straight sideways, it means that there's a group function to the side it's going to, and maybe it'll transition to anterior guidance, or maybe it'll transition posteriorly. But a sideways COF does not indicate good anterior guidance. None of these indicate good anterior guidance. So you can use a bad COF trajectory diagnostically to say, you know, look at to the patient, your back teeth are rubbing together too much. You should have much more control over your front teeth. So let's look at some examples of that. Okay, the L-shaped center of force. An L shape always denotes working side group function. Now, before I play the movie, look at the COF, look at the graph. The graph has the orange quadrant in control. The green quadrant tries to take control, but it fails, right? And the balancing side, the blue quadrant, is involved also. Now watch the center of force, how it correlates to the group function that's in the graph. The center of force goes sideways, directly into the group function, then it transitions north to try to get to the anterior guidance. And in this case, the anterior guidance fails, as you saw there. So watch the center of force again. It goes directly sideways into the group function, and then as the back teeth somewhat dissipate, it tries to go forward. That always indicates group function. This is the L, right? Right here. That makes an L. Here's a really good example of an L-shaped COF. This was sent to me from a dentist who was questioning, you know, how he was doing with his case. Watch this center of force, how far to the right it goes before it turns north. Goes all the way into the first molar, past the parallel cusp of the first molar, into the central fossa. Now it's turning north, right? That's group function. Now look at how it correlates to the graph. The person's going to the right, the blue quadrant rises, that's the posterior right. Then the anterior guidance takes over late. So that's why you get an L shape. The group function precedes the anterior guidance. That's why you get the L shape. Okay, now, the struggle to disclude the posterior teeth can also be seen in the center of force, how it jogs and changes direction, even in 1 to 2 frames at a time. Every little red and white segment is 0.003 of a second. So when it's jogging, meaning it's not, you know, going where you want it to, it's actually being influenced by teeth on one side of the arch or the other. And this is a really good example. The disclusion time is very short, but the center of force struggles to get out to the canine. See, it jogged posteriorly, right? Now it's jogging sideways. Now it's heading north like it's supposed to be, but then it goes sideways, and now it finally takes over and gets anterior. And those are the things, this area, the patient complains about their bite and they don't like the way their excursion feels. This is the piece of the movie that matters, right? What's happening here is being reflected in the teeth, right? And you see these columns fluctuating. This whole side is still involved, and the anterior guidance is working, and it finally takes over. And when it finally takes over, that's when this shoots up there. So lots of little jogging around means the guidance isn't that good either. So even with a short time frame, right? The time frame is a guideline, but these are also reflections of the quality of the result. The time frame may be great, but the pathway may not be. So you might have to do a little more work there. A looping COF. This is a really good example of a looping COF. Now, again, reading the graph before we play the movie, this is a real struggling patient. Their jaw's vibrating. Right? They're unable to close quickly. The A to B increment is very horizontal. That means they're afraid to bite down. Then they finally peak out and they begin to let go of their forces, and they're vibrating, their mandible's vibrating the whole time. And here's where they begin their excursion. And when they begin their excursion, their blue quadrant is in control. The red quadrant tries to take control but fails, and the orange quadrant actually wins out and takes control. And that's reflected in the center of force. Watch what the center of force does. It's going to head to the right. Now it's going to turn around and go back to the left. a looping COF, never a good thing to see. Okay? Really important to record, never a good thing to see. Now, here's a very interesting loop. It's a reverse loop. Okay, so remember I said to you, the center of force reflects the force changes in the teeth where it moves to, not the movement of the patient. So in this very unique example, this patient is actually making a right excursion. And you can see that in the graph because the red quadrant tries to rise, and ultimately it does rise, And the blue quadrant also is in the way and does rise. But notice at the beginning, the orange quadrant is really the main player, and there is friction. And that's all coming from these balancing contacts because the patient is moving this way. But you'll see the center of force is about to go left because the forces are going up here before the patient moves far enough off of these teeth that the transition goes towards the anterior right, right? So there's a left side control, which is dissipated by the posterior right and then the anterior right. And again, this all happens in very little time frame, 0.8 of a second. So watch the center of force. First, it's going to go left. The patient is going to the right, right? But the left side is such a blockage that the center of force goes there first. And once this starts to dissipate, now you see the center of force transitions to the right. And there's the anterior guidance finally working. So you might look in this patient's mouth and say, wow, they have anterior guidance. They have canine guidance, you know, visually, but not when you record it. When you record it, you have group blockages on the non-working side that precede the ability of the anterior guidance to take over. And then you see the center of force quickly switch to the right as soon as the patient has moved off of these teeth. Now, after we treat this person, and you see we've left mostly central fossil contacts and small cusped tip contacts, although there are flaws. There's a flaw right there. There's a flaw right there. There's flaws right there. It's very hard to get a perfect paper mark pattern. And it is reflected in the data because here you see the patient, they begin their excursion, they stop moving. Whenever you have a horizontal period in a graph, it means the person stopped moving. So just think about that for a second. Here they're biting down. They're in MIP. They stop moving. You have a horizontal line. Well, if they make an excursion and suddenly there's a horizontal line, it means they stop moving. So here they stop moving for maybe a half a second, and then they continued on towards their anterior guidance. So you can see now the center of force tracks much more towards the anterior guidance and is not starting out going left. Yet they're still back teeth bilaterally, right? In 0.4 of a second. This is a very good COF trajectory. It's heading towards the canine. The closure pathway is fairly balanced. This comes down the middle of the center, the T-scan arch, and then this goes out to the side. Right? All through T-scan guided adjustments can you make those kinds of corrections. Here's an interesting one. This patient has what appears to be good canine guidance, but they have poor occlusal orientation. This is obtuse angles to each other. Anytime you have teeth that angle like this and angle like this, you have lots of interferences. And you've all seen this clinically. So this COF is a bending COF. Watch what happens. It's trying to go to the canine, and now it's going to turn backwards. Right? See, it goes backwards. Anytime you have a bend, you have working side group function. Right? The guidance is there, but not fast enough. It doesn't bring the canine, it doesn't bring the center of force to itself. The bend is a function of the orange quadrant. See how long the orange quadrant is active? And that patient's class 1, right? Canine's class 1 molar, class 1 canine. And you see how long it takes them to get to their anterior guidance, 2.4 seconds. Then we treat them. And again, this is their lower left side. This matches up to these teeth here. Now watch, when we treat them, what happens to the center of force, how it goes directly towards the anterior. And even though back teeth maintain a small amount of contact, short duration contact, right? So this is a near ideal center of force trajectory. The closure trajectory is ideal, and the left guidance trajectory is ideal, right? And that's the result of T-scan guided adjustments. Okay, so let's see the next image. Okay, protrusion. Now, as I said in the beginning, I talked about protrusion not being that crucial when it comes to treating someone, but it is essential to analyze. And there are times it is very important to analyze. For example, if you have a very roller coaster plane of occlusion, if you have second and third molars that stick up in the air on the bottom, you know, if they're like their back end is raised or the plane of occlusion is depressed in the middle and very high posteriorly, protrusive interferences are going to be very prominent. This one is just a really good example of what you can see in a protrusive interference. So again, read the graph first, right? What happens? The posterior right is in control. The posterior left maintains some contact. And in protrusion, you tend to share the guidance between the right centrals and the left centrals. So that's why you see the red and the green lines running together. But watch what happens to the center of force, how it marks out the fact that the right side is a problem. Watch what happens. The center of force is now going to go backwards, right, towards the 1-7, which is staying in contact. And now it's beginning to drop. And when it drops in force, that's when the center of force turns north, right? So this piece of it right here, if we play it again, this early piece of it is critical in being able to know what to adjust, which is from this area and from this area. And then once it dissipates, then it takes on a normal character, right? So that's the beauty of following the center of force. It shows you where the flaws are. It points out where the problems lie. Now, this comes from a course we used to give where we would put up a picture like this and say to the group, what does this COF illustrate? Right? So you can think about these things, but I'm going to go through a few of them so you can reinforce what you're seeing. So the first thing to note is this is the side that the person is moving to, because you see there's a lot less teeth on this side in contact, right? So here's a perfect example of working side group function that precedes anterior guidance control. So anytime you have a sideways COF and then a northward movement, it means that the anterior guidance is late. This happens a lot when people can't hold their MIP. So the patient's biting down and they get to MIP and they can't hold it, so they start wavering and the center of force jogs back and forth. And then in this instance, and this is really a good example of what happens, the patient is moving to the right. You see all these teeth are involved in the excursion. The left side is coming apart, but the center of force in the excursion goes left because 15 controls the movement. It has much more force in it percentage-wise than the entire right side. So it drags the center of force towards itself. It may not stay there. It may actually turn around and go towards the right later on. But this is a really good example of the center of force going to the direction that the person is not moving. The person's moving to the right, the center of force is going left. Okay, so here, this patient bites down, they press forward against their front teeth, then they start to close, and they come down to MIP, and they can't hold their MIP. So you see the wavering of the COF. And when they're wavering, what's happening is they're letting go of their MIP, and the center of force is drifting towards the side that the MIP has more force. That's in this period. So it's drifting to the left. And then when she actually moves to the right, the center of force, instead of going to the canine, goes to the first molar area, which is taking up 50% of the excursion. Right? So here you can see there's less teeth on this side. You know she's moving to the right, but the center of force is going towards the posterior teeth. This is a backward COF. You never want to see that either. That and the looping ones are the worst ones. This one has a very right-sided closure COF. So here the patient's biting down, and they end up here at MIP, and then they go to the left, and they have decent anterior guidance, but notice how they jog, right? So this piece of it is a balancing contact that comes up in the middle of the excursion, somewhere over here. Don't know where we're after that. We're showing the frames after that. But see how it jogs, which means that the back teeth stay in play, even though there's anterior guidance. Right? Fairly good left anterior guidance control. Not great left anterior guidance control. If it was great, it would just go like that. This one shows you good balance and closure, a group function, anterior guidance taking over, and then a bend means the anterior guidance fails. Remember the bend backwards, right? So the guidance control is greatly affected by tooth number 15, even though number 11 is in play. Okay, so this is my last slide. When you make corrections to the occlusion that are measurably beneficial. And that's really what digital measured occlusion is all about, that you're using metrics to know that you've made beneficial improvements that are beyond the patient saying, yeah, I think it feels good. The patient has to say it feels good, but they could say it feels good and it could be 65% left, 35% right. They're not that precise. So all three things will change when you improve excursive function from T-scan guided adjustments. So if we look at the pre-op, right, and we look first at the COF, right, the COF is balanced in closure. It jogs left, then it goes right, then it jogs left, then it goes right, and it's nowhere near the anterior teeth, right? It's all in the middle of the posterior teeth, so this is not going to work. And you can see that in the graph, right? The graph has friction. The blue quadrant is in control. The orange quadrant doesn't go away. That's why the COF pathway is having a hard time getting towards the anterior. But when we fix the guidance by T-scan guided adjustments, the center of force does what we want it to do, right? And again, the timing table reflects those changes, 2.18 seconds from when the excursion begins to the complete posterior disclusion versus 0.36 seconds. But again, 0.36 seconds, there's still back teeth in play, so don't be fooled by the timing. The graph shows you the true story. And the last element that improves is the graph, right? How close are C and D? How fast does the anterior guidance quadrant take over? What happens to the posterior lines? Instead of them traveling across the screen and instead of there being all this friction, right? Now there's very little friction, if any, and the two colored quadrants, blue and orange, they basically drop force to zero and the anterior guidance takes over. So those are all the things you can see if you improve the occlusion. And all of them are markers for dysfunction, right? These are all markers for dysfunction. Long DT, friction in the graph, lack of anterior guidance control, group function, balancing contact, bad COF pathway. That's all dysfunction. Corrected with metrics. That's digital measured occlusion with the T-scan. Now, if you want to learn more about all of this, Dr. Sutter and I are giving a course in Denver next, I think it's in 2 weeks, September 29th. And it's a one-day devoted just to the T-scan. How to record well, how to use the information to install implant dentistry, how to use it to choose the right paper marks, how to set up the arch correctly, how to make good excursive recordings. And we have a hands-on, and we have the both of us lecture on different topics. And we hold these courses, we hold these courses at the Vivos Institute. Let's see if I can get back to that, which is in Denver, which is a very nice educational institute. This course happens to be 1 day. And if you use this code TSCAN23, you'd get a discount for attending. And you can register at the Vivos Institute. They have a website. Just look it up online if you're interested. The other way to learn, and this is by far the best way to learn, is to have in-office training or have online Zoom training where I guide you through all of it. You can be taught on Zoom with a staff member how to record properly and how to analyze your data. But if you really want to learn how to use your T-scan effectively, chairside training with implant patients and prosthodontic patients or TMD patients, you're going to really learn how to use the T-scan, not only to diagnose, but to treat and to control your outcomes with metrics. Learn data analysis, learn how to install a high quality outcome as you treat patients with guidance from me. And if you're interested in that, you can go to my website. You can see testimonials from doctors who've had one-on-one training. I've been teaching dentists for years and years. One-on-one is by far the best way. Dr. Sutter will tell you he learned more in 5 to 10 minutes of one-on-one training than he did after owning the T-scan for 5 years. And you can ask him that, and he'll tell you that. If you're interested in reaching out to me about one-on-one training, you can contact me by email or by my phone number. But that is by far your best way to learn, fastest way to get past the T-scan learning curve. So I'll take any questions, and I want to thank TechScan again for offering these training webinars to all of our users. They're a great way to be able to teach you a topic, and these are all very important topics. The way to record, the way to read the graph, the way to understand all the software features. So I just want to thank you for your attention and time, and I'm happy to take any questions.
Thanks, Dr. Kerstein. And that was a really, really good presentation. I think that even if you've been watching this whole time, I would reiterate that this is being recorded, so watch it again because there's a lot of good information. I think you'll pick up even more the second time watching it on there. Also, I want to just reiterate what Dr. Kerstein was saying about in-office training. It is probably the best investment you'll make for your practice is to have someone like him come out to your office and actually do that. It's basically over the shoulder training, right? He's actually helping you understand what you're looking at. He's helping you correlate the information from the T scan to the patient's arches. It is one of the best ways to learn it. And my clients that do bring him out to the practice rave about how much more comfortable they feel when they're working with their patients, and it gets you more efficient, which makes you quicker, which in the end, there's a pretty good ROI for that as well too. So I do recommend that if you are able to bring Dr. Kerstein out to your practice to do in-office training. So we do have several questions. And if you guys have questions, feel free to put down in the Q&A. So let me get to those questions. Gotta take my glasses off because I can't see close up very well. From Dr. Murala, is it always necessary to correct the occlusion until we get canine guidance, or can we leave in-group function if the disclusion is below 0.4 seconds?
That's a very good question. The disclusion won't be below 0.4 seconds unless it's treated. We've done many studies where we've measured just natural tooth patients who have just how they present, and class 1 patients who have canines in contact and molars in class 1, their mean disclusion time is 1.2 seconds, which means class 1, which has the best potential anterior guidance, doesn't have a disclusion time that's less than 0.5. So, but to answer your question, so you understand, you only really treat someone who has evidence of a need to be treated. So what would that be? They have recession and abfraction. They have occlusal wear. They have some mobile teeth. They have occlusal muscle dysfunction. They have tired chewing patterns. They have headaches. So there's physical reasons to treat the occlusion, and there's physical as in patient physicality, like symptoms of pain and muscle dysfunction, and then there's dental reasons to treat the occlusion. If you see wear facets, gum recession, mobile teeth, slight bone loss around certain teeth, you definitely want to look at their closure pressures and their excursive function. And then you can arrest these problems. But if you look in their mouth and they have no tooth wear, and they have no gum recession, and they have no root denting, and they have no TMJ symptoms, then they're going along fine. They have no periodontal pocketing. Whether they have, let's say, bad T-scan data from the standpoint of, good occlusion versus bad occlusion, they're not destroying their teeth with it. They're not suffering from it. So that's a physiologic occlusion for that person. And so that's a person that you wouldn't necessarily treat. The treatment protocols really apply to people that are having wear and tear on their teeth, who present with symptoms, or when you're delivering prosthetic dentistry. Those are the places where you would definitely use the T-scan. And so it really comes down to the patient's condition as to whether you go forward and institute treatment protocols, right? That's really the gray area. So someone could have a beautiful occlusion, and you've all seen it. A 25-year-old female had braces, looks gorgeous, class 1. She's got headaches, she's got migraines, she can't wake up without jaw pain, she can't chew gum, she has earaches and eye strain, and she's someone who you're going to need to treat, right? But someone else comes in with a few missing teeth, they have third molars, their occlusal plane is kind of sloping, but they have no gum recession, they have no wear, they have no recession, and they're chewing fine, they don't have headaches, they don't have earaches. You don't have to realign their teeth and move them to orthodontically make them perfect. You don't have to fill in any spaces with an implant. They're going along like living well, right? So you have to make that clinical determination per patient. And that's where the data then becomes the conduit to be able to figure out what's wrong with an occlusion that's destroying itself or that's creating pain and chronic dysfunction for the patient. The T-scan will allow you to see what the true elements are that need to be corrected, and then you can go in and make appropriate corrections, which isn't always adjusting the bite. It might be moving some teeth and then adjusting the bite. It might be adding contact to a side that's under forceful. You know, there's a lot of opportunities, and this is again where one-on-one training really comes into play. You bring in patients that you think you want to treat, and they have problems that you haven't been able to resolve, and we deal with it right then and there.
Okay, thank you. So the next question, we have several questions here. So next question is from Dr. Racino. He says webinars have helped me to really make full use of my T-scans and new user this year. So his question is, which EMG3 system do you use to link with T-scan, 4 channels or 8 channels? And if you use 4 or 8 channels, what region of the masseter and temporalis do you place the pads?
Okay, so I have the 8-channel EMG, and I use that when patients have neck involvement and throat involvement, submandibular involvement. Otherwise, I'll use 4-channel EMG, which means we'll use the masseter and temporalis. So most of the time, I would say 75% of the time, we're using masseters and temporalis synchronized with the T-scan. But you can set it up to have 8-channel if you want that. And I would say there are definitely patients that benefit from having 8-channel analysis. The second part of the question, the placement of the leads is always over the contracted bulk of muscle along the line of the muscle fibers. So you actually feel for the masseter. You have the patient clench and bite down hard, and you can feel where the muscle bulges out, and we teach you how to do that very predictably. With the temporalis, you pull back the hair and you have them clench, and you look to find where the contracted anterior bulk is, and you put the leads directly over the bulk of muscle. So, with a bald person, you could actually truly put the temporalis lead on the bulk of the muscle. But for most women and men who have hair, you have to put it over the anterior fibers, which is here. But it's always over the contracted bulk of muscle.
Awesome, thank you. The next 2 questions are more about where can they find the previous webinar sessions. I'll make sure that we send everyone here, that link to our website that allows you to get access to the previous session, which one of them is the graph session that Dr. Kerstein alluded to earlier in the webinar. So we'll make sure to get that stuff to you. The next question here is thickness of the articulating paper when you register MIP and excursive.
I think I mentioned we try to use 20 to 30 micron carbon paper. We found, first of all, there's scientific validity for using that. It has nothing to do with the T-scan per se. It's been shown in studies that 20 microns or less leaves the least number of false positive markings. So that means you don't get extra marks because the paper is thick and it leaves lots of ink around that actually is in contact, right? So that's very important from the standpoint of treating people. When you correlate T-scan data to a high force, let's say enclosure on a second molar, you don't want false marks. You only want the contacts that actually exist. And then you can map that very well to the T-scan arch when you've set up the T-scan arch correctly, which is, again, a skill, an essential skill. That is really wonderful about the T-scan, because you can customize the arch. You can take out premolars. You can create edentulous spaces. You can put in an extra tooth if there's an extra tooth. You can add implants. There's all kinds of things you can do with it, so that it makes it much easier to find the contacts when the arch is set up correctly. So that's why we use 20 micron carbon paper, because it doesn't give you false extra markings. Once you get above 40, you start to get a lot of extra markings. And some dentists like that. They'll tell me, well, I can't see anything unless there's a lot of ink. But what happens when there's a lot of ink is you do a lot more grinding than is necessary. And that's a real problem, because too many marks that don't actually have functional contact, they're just artifacts because the ink laid down ink because the teeth rubbed together against a thick piece of paper. That's going to throw off your ability to find the right marks. So keep it. We use most of the pictures you'll see when I lecture, if not all of them, our Accufilm. Accufilm 2 is 23 microns thick. It's made by Parkel. And you can use artist foil, that's 12 microns. You can use anything under 25 microns is going to be going to give you the least number of false positives.
Thank you. The next one's more of a statement from Dr. Yates. Great info. Every dentist should own a T-scan and know how to use it. I 100% agree with that. I'm sure everybody here would agree with that too. Appreciate the webinar. The next question is from Dr. Papel. What is the position of the patient in the chair when you register with T-scan?
Well, that's a very good question. So as you saw in the video, I was in a seminar room. The patient was sitting upright in the chair. In the dental chair, I have them sit upright. For diagnosis, I have them sit upright, the chair slightly back, like 85 degrees, not 90 degrees, and their head always against the headrest, because people can bite harder when their head is stable. And it isn't that they need to mash their head into the headrest. They just have to have it against the headrest. So they're slightly back and upright. But when I'm delivering 14 units of crown and bridge that are uncemented, and I can't sit them up every time to try them on, to take their bite, because all the crowns are going to fall off and fall into their mouth, we do all the recordings lying back, and then we reglaze the case and bring them back, and when we deliver it, we make some upright recordings. So you can choose the position you want to record in based on the scenario. True diagnosis, like just to analyze someone's bite, 85 degrees to vertical, head against the headrest, all recordings made in the dental chair like that. But inserting prosthetic dentistry that's uncemented, that falls off, that could drop down somebody's throat every time we sit them up, no, we do it all lying back. And there's no right or wrong there. You have to manage the clinical situation, and so that's something that there's some latitude in. But it's sort of like, for diagnosis, it's best to have the patient seated upright. But clinically, for installation of complex cases, it might not be so good to have them sitting up.
Next question from Dr. Papel. Top 3 rules for occlusal adjustment.
Measure, measure, and measure. So you know what you're measuring and treating, right? Those are 3 rules, right?
That's a good, I like that answer. Yep.
But in essence, just to give you some guidelines that are helpful, with natural teeth, you're much better off treating the excursions before you treat the closure. You can definitely improve the occlusion a lot faster by not focusing on the balance and focusing on the functional movements, and then coming back to the balance. And we do that all the time with disclusion time reduction. We've been doing it. We've been actually, my first paper about shortening the disclusion time talks about treating the excursions before addressing the closure. And one of the common problems people have when they begin working with T-scan is they'll often work on the A to B side on a natural tooth patient. And what happens when you do that is you make the teeth fit together better, but they often fit together excursively worse than when they started. So you take away some closure forces, but now the teeth engage worse laterally. And sometimes that will raise symptoms. So the natural tooth patient, in the correct protocol, if you're going to try to treat their bite to optimal function, you would start with excursions first. And this is something that we teach you when we train you chairside on DTR. When you're doing prosthetic dentistry and you're installing crowns, you're installing implants, you're installing hybrids, you're installing overdentures, then you start with A to B and closure. And the reason for that is twofold. First, the cases are never really down. In other words, when you get them back and you put them in the mouth, I'm a prosthodontist, so I know this. I spent my whole life delivering dentistry. The way it looks on the articulator, or a virtual articulator these days, it's never that way in the mouth. And so you have all these fake materials, meaning you have ceramics, you have post and cores, you have abutment screws, you have zirconia, you have all these faulty materials that are prone to breakage. And so what you want to do with prosthetic dentistry is bring the vertical down and level out the forces in closure, get the center of force in the middle of the case, get a straight line closure center of force, and then treat the excursions. because you need to balance the bite to preserve the dental materials. So the protocol is completely reversed from the natural tooth patient. So those are the two guidelines. The third rule is measure. Know what you're adjusting. Make the T-scan arch match the patient. Don't just go with an empty arch. I can't tell you how many people send me their data and there's no teeth filled in. There's no teeth removed. There's no gray areas. There's no implants denoted. There's no way to find the contacts that way. You have to match the T-scan arch to the patient. And that's one of the great things about the T-scan is you have that capability. Other digital tools for occlusion don't have that capability. They have generic arches that you can't manipulate, and that means you can't find the contact that matches up to the high force. So it's one of the great things about the T-scan. Make your arch customizable, match the data to the patient properly, and set up the arch that matches the patient, and measure.
Great, thank you. So we got a couple more questions here. This one's probably a little bit easier from Dr. Marala. Which burr is needed to be used to correct the interference?
Well, if you want to be efficient, it's best to use a medium grit diamond. And we found that over the years that trying to treat the occlusion effectively and not tire out the patient is a combined effort. You want to be efficient treating them, and you want to do it relatively quickly for them, so that if they're dysfunctional and they get tired and they come in with sore jaws and headaches, that you can actually fix their bite in one session. So to do that, you need a medium grit diamond burr, a round burr, a number 6, a football 6 or 8, something that has some cut to it, and you should be able to treat them. There in disclusion time reduction, we teach you how to treat one side, top and bottom teeth, in 3 to 4 passes, the whole side, and then you do the other side in 3 to 4 passes, and you don't record in the middle at all until you're done with the gross correction, because you don't want to tire the patient out. And when you record in the middle, all you find out is, yeah, it's not done. And even if you record when it's done, the gross correction, it's still not done. So we wait until we have an ideal visual outcome, and then we measure that and optimize that. And that's why one-on-one training is so critical. You learn how to do all those things right then and there, and you're trained how to do it very effectively, very effectively.
Awesome. The next question, also from Dr. Marala. One last question: how much should the occlusal time be after correction? And then a second part to that question is, I think she's asking, when the muscles are overactive, is there any value for interpreting EMG?
Well, so the first part of the question, a highly effective OT is less than 0.2 of a second. So that's from first contact to static intercuspation. And the black line in the graph should rise very straight from very, very little horizontal element to it. It turns horizontal at B when you reach static intercuspation. So you have this rapid time from first to last contact, and that's typically less than 0.2 of a second. Is there any value of measuring muscle physiology with EMG? It's absolutely, it's incredibly valuable. It's state-of-the-art occlusal diagnosis is the T-scan EMG. It shows you all the problems with the occlusion, and it's synchronized to the exact muscle physiology moments. So if you have, prolonged group function going to the right, the muscle physiology reflects that. And when you fix the prolonged disclusion going to the right, the muscle physiology calms down right away. That's why the treatment is so effective, is that we can monitor the measurable physiologic outcomes both at the dental side, the T-scan side, and the muscle physiology side. So yes, they are, T-scan EMG is state-of-the-art diagnosis. There's no question about that. And there's tremendous value for you and for the patient by having those two technologies synchronized together.
You'll find a lot of times that you think you're done, but the EMGs will tell you that you're not done on there. So it really is valuable to have those two technologies combined.
So what Shane was meant by that is, let's say I treated a patient and I got my disclusion time on the right excursion down from 2.3 seconds to 0.6 or 0.5, which is, let's say 0.5, because that's the theoretical physiologic low limit. And then when we look on the EMG of the same recording, there's muscle spasm in that 0.5 of a second in the right temporalis. That's very visible in the EMG. Well, that means we need to deal with that. What's causing that spasm? We can actually click in the EMG right onto the spasm, and it'll show you which teeth in the T-scan are causing that spasm, which contacts and where they are. And then you can go in and treat those specific contacts, and then you'll make a new EMG recording and the spasm will be gone. And so there is no way to know the degree of outcome that you've achieved with the T-scan alone. Although the T-scan alone can optimize the occlusion tremendously well, but in a pain patient, in a muscle physiologic compromised patient, the EMG is a huge part of knowing that you obtained the right outcome, or if you have to fine tune more.
Perfect. And the last question that we have here is from Dr. Flanagan. Says I've been a T-scan user since 2000, and I will tell you that T-scan is the ultimate technology for computer-guided occlusions. Just one question: what is the best way to get my chairside assistants up the learning curve?
Well, that's a very good question. One is to have them be trained as part of an in-office training, which is definitely what goes on. Many of the offices I go to, they have the staff learn to record. They have the staff do the recordings and to do the T-scan analysis while the doctor oversees them. I'm overseeing all of them. But having them participate in chairside training is really essential, because then they're really on board. Not only do they know how to use it, but they see how helpful it is. You know, a lot of times the staff, if they're not using something new, they often say, well, it's going to take long. He's going to pull out that T-scan. That's going to take time. You know, they don't see the value of it. But if they participate in the training and they're trained on it, they really realize, this shouldn't say it that way, they very much realize what the T-scan really means to the patients and to the doctor getting good outcomes, and they have a hand in it. So chairside training is, for them, is just as important as far as recording and working with the patient. Those are things that chairside training really helps them do. And for the doctor, it's recording, analyzing, and adjusting. Those are the things that the doctor benefits from.
Yeah, and I think it changes the perspective to have your chairside team there to kind of learn not only just how to do the data, but actually seeing the outcomes and seeing what's happening with those patients. It makes them appreciate that part of it even more, and then they want to make this a bigger part of the practice. You know, depending on how you're using it, not just using it to finish cases, but even using it diagnostically to help evaluate what's going on with those patients in the first place. So absolutely, if you can, like I said, if you can bring out Dr. Kerstein in your office, I think that's a great way to get your training. That's probably the best way to get the training. We can also do some virtual one-on-one sessions, whether it's through us. I know Dr. Kerstein does one-on-one sessions with people as well,
On Zoom.
virtually,
Yes.
if you want to start that way as well too. So that was the last question. Do you want to put your info up there real quick again, just in case anybody wants to contact you?
I do a screen share. Hold on, let me see.
Again, I thank everybody for being here. We still have 40 some doctors that are still on this session this late in the day.
Actually, let me, you know what I have to
I
do?
think it's the previous slide, isn't it?
I have to go to the last slide. Oh, Q&A. Let's see. Oops. Sorry about that. I apologize. I'm messing up the screen sharing. Share. Let's see if we go. I can
I
get
think you
to it.
had on the second to last one.
There we go. I think you can see it now.
Yeah, so if you want to get a hold of Dr. Kerstein, you have his website there. You have his email down below, as well as his phone number. So please reach out to him if you want to talk to him more about whether it be in office or virtual train sessions. Again, I want to thank everybody for their time on being here. No, there was okay. Making sure there wasn't any questions that we needed to answer on there. Thanks for your time, for being here. Like I said, this is being recorded, so if you get a chance, watch it again. And there is a survey I believe, once we stop this recording. So please, if you get a chance, take the time to do that survey because that helps us as well too. So thank you for your time, and I hope everybody has either a great day, a great night,
Thank you so
and
much, everyone.
a great weekend.
Thank you for
Thank
your
you.
time. Okay. Any questions from you, Shane? And